Good afternoon and welcome to the Sexual Health webinar series. My name is Jennifer K. Campbell and I'm a training and consultation specialist at the Global Tuberculosis Institute in Newark, New Jersey. This series provides information and tools to help medical providers better serve the sexual and reproductive health needs of their patients. All webinars will be archived and free CME and CNE credits are available. You will receive an email after this webinar with instructions on how to get continuing education credits. If you are joining us by phone, please make sure that your line is muted. If you have a question, you can type it into the Q&A box at the top of the screen, and we will have time for questions at the end of the webinar. This list shows all of our partners in the webinar series. This is our accreditation statement. Please take some time to review it. We have nothing to disclose. And now I would like to introduce our speaker. Dr. Alfred Larchzabal is a pulmonologist at the New Jersey Medical School and Associate Director of the Global Tuberculosis Institute. He's going to provide an overview of latent tuberculosis infection. Dr. Larchzabal?
Oh, thank you, Jennifer. Can you hear me?
I can, yes, you're good to go.
Okay, thank you. Oh, good afternoon, everyone. I appreciate the opportunity to talk about tuberculosis, latent tuberculosis in particular. Up on screen right now is our learning objectives for this session. I will begin by discussing global and national TB epidemiology. At the end of the session, you should be able to understand the basic concepts of tuberculosis transmission and pathogenesis, describe risk assessment and targeted testing, and understand the tools that are used for the diagnosis of TB infection. And lastly, discuss regimens for the treatment of TB infection, including regimens available for higher risk clients, such as those living with HIV/AIDS. Now, I know this is a series, I understand this is a series on sexual and reproductive health, and you must be wondering where latent tuberculosis fits in. Well, the Rutgers Global TB Institute is one of federally funded training centers, FTCCs, that collaborates on a number of trainings and events. Our centers, as you know, are funded to provide training on topics like HIV, STD prevention, AIDS, substance abuse, etc. The Global TB Institute provides training and education as well as medical consultation for tuberculosis for the Northeast United States. Healthcare providers who see patients in the community centers see individuals for a wide range of issues, besides those solely relating to reproductive and sexual health. And I think they have the opportunity to screen for TB infection and disease in their clients. As I'll discuss during the course of this webinar, not everyone needs to be screened for latent TB infection. The CDC recommends targeted testing strategies, but some patients you see in the community setting may be at higher risk and should be screened and, if appropriate, treated for LTBI or latent TB infection. I'll go into this in more detail, but this includes non-US born people from TB endemic areas, as well as those with HIV and other immune suppressing conditions. Identifying and treating latent TB infection in the community will prevent the development of new cases of TB, which in turn decreases further transmission within the community. Identifying and treating LTBI is an important part of CDC's strategy for TB elimination, and because you all have access to patients in the community who may not otherwise seek care, you can play an important role in this effort. So let's get started. This first slide talks about the global burden of tuberculosis, and on the left-hand side of the slide, you can see all forms of TB. As of 2012, 8.7 incident cases of tuberculosis have been recorded, and that is still quite a high number. Importantly, among the 8.7 million cases that are diagnosed, at least as of 2012, 1.4 million die from tuberculosis, and that's about a 16% mortality rate in 2013 with medications that are effective and for a disease that can be treated. A 16% mortality rate is still quite a high mortality rate. And looking down to the next category, HIV-associated tuberculosis, 1.1 million incident cases or new cases as of 2012, or 13% of all cases for the year. Importantly, among people living with HIV, in this slide, 430,000 people were estimated to have died from tuberculosis, and that is a 40% mortality rate from the incident cases, quite a high number when you look at TB and HIV and mortality. And at the bottom of this slide, childhood TB is the one aspect of tuberculosis that certainly we're trying to shine more light on. If adults have TB, certainly children are at risk for TB too. And as you can see here, it's also quite a high mortality rate. This map gives you a quick idea of where TB incidents are highest, where TB incidence is highest as of 2011. And the darker the shaded blue, the higher the incidence rate or the case rate of tuberculosis. And from this map here, you can see the southern part of the African continent, sub-Saharan Africa, has the highest case rate, estimated to be about more than 300 per 100,000 population. Other high incidence areas in this map you can see are parts of South Asia and Southeast Asia, as well as Eastern Europe and the former Soviet Union. When you look at the domestic issues with regards to TB, we've been doing quite well. And from the case rates on the right-hand side of the screen, you can see a consistent drop in these numbers from a case rate of 4.6 in 2006 to 3.2 in 2012. There was a significant drop between 2008 and 2009, and that was estimated to be about a 9% drop. However, that has slowed down to about 5–6% over the last last couple of years. Our current case rate of 3.2 is the lowest case rate ever recorded since 1953, and that is something to be proud of and happy about. It also poses a challenge. The lower the case rates and TB incidence, the less resources we have in terms of TB control. Here's our trend when we look at the foreign-born TB cases. As you can see from this slide, most of the total case rates, case numbers have gone down consistently, as I've mentioned earlier. However, what's important here is the percentage of foreign-born has consistently increased over the last decade. And nationally, the proportion of foreign-born cases of tuberculosis are somewhere in the range of 65%. Bear in mind that some communities and some states may have up to 75% foreign-born case rates. When you look at the breakdown of where the foreign-born TB cases comes from, the highest countries contributing to U.S. cases are Mexico, the Philippines, India, Vietnam, and China. 3% from Guatemala and 3% from Haiti. I think knowing these is helpful. These numbers are helpful to know what the local risk is for your community. I thought that this might be an interesting slide to also look at. When you pull out the three top countries that have been the sources of foreign-born tuberculosis in the U.S., what you see here is that many of them do develop their tuberculosis within their first fourth year of residing in the U.S., but a majority, a big number still, develop their TB beyond their 5 years of their stay in the U.S. So looking at these numbers, the TB trends in the U.S. is encouraging. The incidence rate in 2012 is the lowest recorded since reporting began in 1953. But the progress or the rate of decline has somewhat slowed over the recent years. When you look at the groups that are affected, there are disproportionate racial groups for TB in the U.S. Hispanics are 6.6 times higher than non-Hispanic whites in terms of the risk for tuberculosis. Blacks have 7.3 times higher proportion of TB when compared to the U.S.-born citizens, other U.S.-born citizens. And this is the greatest disparity of TB among U.S.-born. Thirdly, Asians have 25 times higher proportion of TB compared to U.S.-born. And if you take all non-U.S.-born patients, they have an 11.5 times higher likelihood of having TB as compared to U.S.-born individuals. The next several slides will review transmission and pathogenesis of tuberculosis, just to familiarize yourselves with this. As you know, tuberculosis is an infection that is transmitted by aerosol droplets, so it's an airborne infection. The patient who has active infectious TB has to be able to generate a droplet nuclei containing tubercle bacilli, which in turn is inhaled by the person who gets infected. Bear in mind that a droplet nuclei has to remain airborne. The size of this droplet nuclei has to be to a certain size, which is estimated to be about 3 microns in size, to stay airborne. So there are many variables that are considered when assessing the possibility of transmission. That includes the dose of the infection that's available in the volume of air. So ventilation of the room has something to do with transmission also. There are issues that are taken into consideration with regards to the host in terms of infection, immune health, and the presence of immune suppression are important host issues that have a bearing on infection, particularly with TB. And thirdly, the bacteria itself has certain characteristics that make it more, that have virulence factor that make an infection more, to have more impact on an individual. Now, once the air droplet nuclei is inhaled, this droplet nuclei has to get to the terminal lungs, the alveolar sacs, to establish the infection. The first line of defense are the alveolar macrophages, which ingest the bacteria. During this early period, the first couple of weeks, there is a logarithmic growth of the infection within the macrophages. And it's also during this period that there is a lymphohematogenous spread that's occurring. So the infection can actually travel and lodge itself in other organs. Within 2 to 8 weeks, this cell-mediated immunity develops and starts to kick in, and activated macrophages start to surround this tubercle bacilli. The troops are called in, fibroblasts and histiocytes start to form what is commonly called a granuloma. And this granuloma is sort of a nice barrier or shell that keeps the bacilli and the infection under control, which we will later refer to as latent tuberculosis infection, or LTBI. However, if the immune system is not healthy enough and cannot keep this granuloma intact and keep the tubercle bacilli from further multiplying, then the person starts to develop disease. this focal granulomata breaks down and the organisms escape, start to replicate, and disseminate. This process can occur in any part of the body. The majority of the time, this occurs in the lung. Obviously, it's inhaled, but certainly this process can occur in the bones, in the brain, and other parts of the body. So if you look at active disease, this would, for most patients or most individuals, represent reactivation of a prior infection. In other instances, active disease may represent reinfection after a prior disease. And in other instances, it can be in the form of a progressive primary infection. So once infected, it doesn't pause and become latent, it just progresses. And this occurs primarily in the very young patients or the very immune suppressed patients. So if we summarize the difference between the two, latent TB infection, the person is asymptomatic, has no signs or symptoms or physical findings suggestive of TB disease. The person only has a manifestation of cellular immunity, as shown by a tuberculin skin test or a blood assay for TB infection, such as the quantiferon test, and the person has a negative X-ray. So for latent TB infection, the only thing that is positive would be some marker for cellular immunity to the TB antigens. On the other side of the spectrum, we have TB disease, and here we specify pulmonary TB. So you may have a positive tuberculin skin test or quantiferon skin TB test. You may have them as negative also, however. The chest X-ray may be abnormal, but in some states, such as severe immunosuppression, you may have a negative chest X-ray in pulmonary disease, pulmonary TB. The symptoms may include one or more of the following: fever, cough, night sweats, weight loss, productive cough. Now, all these symptoms listed here, bear in mind, are non-specific. So again, coming up with a diagnosis of TB has to be taken in context in terms of the risk for TB. Confirmation of TB disease, lastly, will depend on a positive smear and culture for M tuberculosis. For this session, however, we're going to focus solely on latent TB infection. Now, the past several years, there's still a lot of science that's evolving in terms of latent TB infection, and hopefully, we're hoping that in the future we will be able to better identify those at highest risk for reactivation among our pool of at least an estimated 14 million individuals in the U.S. who have latent TB. So as we learn more about latency, there are people out there that are at higher risk and are what they call percolators. Moving to latent TB infection, the first step is testing an individual. I'd like you to think of testing for latent TB infection as a targeted process or a focused process. As TB disease rates in the U.S. decrease, finding persons with high risk for latent TB infection is certainly a priority and is an important arm for TB elimination in the U.S. We have to understand and reevaluate who the groups are at highest risk for infection and seek them out, test them. Targeted testing assumes that treatment of latent TB is required for TB elimination. Targeted testing essentially should identify and treat persons who are at highest risk for TB. And the easy way to think about this is who are at highest risk for infection with MTB, and the second big group are who are at highest risk for developing tuberculosis disease once infected with TB. They're those individuals that we want to focus on in terms of TB screening and treatment. So let's look at the first group. Who are the highest risk of people who might have TB infection? On top of that list, obviously, will be close contacts of individuals who are diagnosed to have infectious pulmonary tuberculosis. They certainly are at high risk for getting infection and at high risk for developing disease if they're infected. So they're on top of the list for people who should be tested for LTBI. Others in this group for high-risk infection would be recent immigrants from high-incidence countries. If an individual is a recent arrival from a high-incidence country, and here we say within the last 5 years, it's important to screen them for TB infection. And the thinking here is many of these individuals may come in with recent infection and may benefit tremendously from treatment once identified to have TB infection. Other high-risk groups are low-income groups with poor access to health care, including the homeless, people who use illicit drugs, people who live or work in high-risk residential settings such as shelters, nursing homes, and correctional facilities, healthcare workers who serve high-risk clients, certain high-risk racial or ethnic populations, as well as locally defined groups. And lastly, infants, children, and adolescents exposed to adults with high risk for infection. Moving to the next big group, who are those individuals at high risk for progressing from latent TB to TB disease? And this is a table of the relative risk of individuals in terms of comorbidities and TB infection from the New England Journal by Dr. Horsberg. And as you can see from this list, the ones at highest risk for progressing from LTBI to TB disease would be those with HIV infection, particularly advanced untreated HIV infection. They have 10 times more risk compared to a non-HIV infected person who has LTBI to develop TB disease. And as you move down the list here, close contacts have a six times higher risk of developing TB disease compared to plain old patient with LTBI and no other medical risk factors. Moving down, individuals who have X-ray findings suggestive of old healed tuberculosis, which if you kind of serendipitously stumble upon fibrotic upper lung changes suggestive of old TB and the person's asymptomatic, they're at high risk of developing TB. They should be screened for latent TB and given treatment for LTBI if they're identified to have LTBI. And moving down the list, more or less about 2 to 3 times higher risk would be those who are on prednisone, TNF-alpha blockers, those who have chronic renal failure, chronic kidney disease, and poorly controlled diabetes, as well as malnutrition. All of them are kind of clumped around the 2 to 3 times increased risk of developing TB, but they're the ones that we see the most of. We see a lot of people with chronic kidney injury. We see a lot of diabetics out there, and they're an important group to consider. And on the bottom of the list, a risk factor we don't focus much about with regards to TB and risk are heavy smokers. And here it's estimated that smokers have a 1.5 times higher risk of progressing to TB disease if they have LTBI. So summarizing, people at high risk for progressing to TB once they're infected are people living with HIV, people recently infected with MTB within the past 2 years. So those would be primarily close contacts of infectious TB cases, or those who have recent documented recent conversion from negative to positive, such as healthcare workers who were negative on screening at work last year and come back this year for another test, and they are positive. So that essentially tells you they've been recently infected. People who use illicit drugs, infants and children younger than 4 years are at high risk for progressing to TB disease once infected, and that whole list of conditions or medical comorbidities that increase your risk to progressing to TB once infected. Again, highlighting those who have diabetes that's not well controlled, hemoglobin A1Cs that are above 7 tend to increase your progression rate. Chronic kidney disease, cancer, intestinal conditions here, as an example, would be those who have GI bypass surgeries in the past, and of course, those who have immunosuppressive therapy and malnutrition. Moving on to the test to use, let's familiarize ourselves with what's available. As you know, most of you may be familiar with the tuberculin skin test using the MANTU technique. This skin test produces a delayed type hypersensitivity reaction in persons with MTB infection. And the other form of TB testing would be interferon gamma release assays, which is a blood test that measures the amount of interferon gamma released by sensitized T cells upon exposure to TB antigens. Let's take the next several minutes to just review what the MANTU tuberculin skin test is. As you all know, the tuberculin skin test is the most common method of skin testing for MTB infection. The tuberculin skin test is a useful test and is an inexpensive test. However, it does require more work. It does require 2 visits from the patient, one for the administration of the test and the next visit for an interpretation of the results, which is done about 48 to 72 hours after the test is applied. So how do you apply the test properly? You are to inject 0.1 cc's, 1 ml of 5 TU strength purified protein derivative intradermally on the volar aspect of the forearm. And from the picture here, you can see a round wheel. You have to produce the wheel for this test to be considered properly administered. The wheel should be about 6 to 10 millimeters in diameter. So the depth of your needle is important. It has to be intradermal, and you have to see a wheel upon administering the PPD. 2 to 3 days later, the patient is to return for interpretation. The patient cannot call in an interpretation. The result is measured, and it's really the induration that's measured. And as you can see from the picture here, you have an induration here that's about 15 millimeters, and the erythema around it is far bigger. But what you really should be interested in measuring would be the induration, which is felt. You measure transversely along the long axis of the forearm, and you record the results not as positive or negative, but as a size in millimeters. So this is a process that involves a lot of training and a lot of interpretation strategies, and so those are challenges with regards to this particular test. In terms of interpreting the test, you can see here a breakdown of different thresholds for skin test positivity. On the top of this table, anything 5 millimeters or greater is considered positive for those at the highest risk for progressing to TB disease. And as we reviewed earlier, the ones with the highest risk for progressing to TB disease are those with HIV co-infection, recent contacts to persons with active TB disease or recent converters of their skin test with indicating new infection, persons with evidence of old healed TB lesions on x-rays, and immunosuppressed patients on steroids, chemotherapy, TNF-alpha blockers, and such. In the middle part of this table, 10 millimeters or greater is considered positive for pretty much everybody else. And I will not read through this, but it's the others in the group that we consider for testing. Biggest here would be those at high risk for infection and those who are recent arrivals from high incidence countries. 15 millimeters is the cutoff that is used if somebody so happens to get the test and has no identified risk factor for TB infection. So kind of the bar is raised higher for positivity if the likelihood of infection is not identified and generally have no reason to be infected. But when you think about it, these people really shouldn't be tested. Moving on to the various blood assays for TB infection or interferon gamma release assays. The U.S. has 2 that are currently approved by the FDA. The first and more commonly used, and probably many of you are more familiar with, would be the quantiferon test, specifically the quantiferon TB Gold in-tube test, which was approved in 2007. The other available blood assay for TB is the T-spot TB test, which was approved a year later in 2008. So we have about a decade of experience now with these blood tests for TB. So how do these work? Again, as I mentioned earlier at the start of this discussion, it involves mixing blood samples from patients with TB-specific antigens from M. tuberculosis. These tests have positive and negative controls. The blood is incubated for 16 to 24 hours. Now, if the T cells that are in this blood have been primed by prior infection, they will recognize the antigen and release interferon gamma. The amount of interferon released in response to tuberculin or the TB antigens is then measured. And for quantiferon, it's an ELISA. This graphic here shows you what exactly happens between these 2 tests. So you have the antigen that's exposed to the person's T cells. If the T cell has been primed prior, it will release cytokines. Here we have TNF-alpha, interferon gamma, IL-8, and other cytokines, which are involved in cell-mediated immunity. And on top of this cartoon here, this is basically what happens when you do a skin test. The only thing is that it's in vivo. For the blood test, you again expose the blood to the TB-specific antigens. And then for our current blood tests that are available, it's the measurement of interferon gamma in the lab that's done. I think it's important to understand how the quantiferon test is done and what exactly gets into the what's the process of determining a result. So first, blood is drawn. About 1 cc of blood is taken and is put into each of these 3 tubes here. Here we have the nil tube or the negative control tube. In the bottom, you have the positive control tube, which has mitogen, which is a general stimulant for T cells. And in the red tube, this tube is lined with TB-specific antigens, ESAT6 and CFP10, as well as TB7.7. These 3 antigens are TB-specific antigens. The blood is then exposed to the antigens by shaking the tube once filled with blood, and then incubated. The gamma interferon is then measured about a day later. And here's how to interpret a result, or how a positive result is obtained. The person has to have at least a 0.35 international unit per ml TB response or interferon gamma response, and it has to be greater than 25% of the interferon gamma response from the negative control. It should also not have a very high nil response in terms of gamma interferon. Otherwise, if your nil response is high, the test becomes indeterminate. So essentially, the negative control shouldn't have too much of a response. And you also want a very robust response from your positive control. If you don't have a robust response in your positive control, you have a test failure, and it becomes indeterminate. Now, the T-spot essentially, in general, uses the same idea, basically stimulating T cells and looking for response. The methodology is, however, just slightly different here. So blood is drawn, it's spun down, peripheral blood mononuclear cells are harvested or separated. A quantitative measurement of 250,000 PBMCs is counted and exposed to TB-specific antigens and put into plates that have antibodies to gamma interferon. This is incubated overnight and then washed and then re-exposed to another gamma interferon antibody, and then spots are counted. Each spot means a T cell that sends out gamma interferon. As you can see, it's a little more tedious in terms of the steps involved, a little more involved in terms of the process and the methodology. And for a positive result, you should, there should be about 8 or more spots counted. Again, like the quantiferon test, you shouldn't have too much of a negative response, and you have to have a good mitogen response. For the T-spot test, they have a so-called borderline region, wherein if only 5 to 7 spots are counted, they are going to not say it's negative or positive. So they're giving you that buffer zone of indeterminate borderline, neither negative nor positive. And then you have a negative result if you have 4 spots or less on your TB response. Again, test failure if you have too strong a response in your negative control or too little in your positive control. Summing it up, a negative IGRA test is interpreted in the same manner as a negative skin test. No further TB evaluation is needed unless indicated by clinical judgment, obviously. A positive test is the same as a positive tuberculin skin test. This should be preceded by a medical evaluation and a chest X-ray to exclude TB disease and confirm latent TB infection. As I mentioned earlier, an indeterminate result indicates a test failure, and the approach that is recommended would be to repeat the blood test or do a tuberculin skin test. And for the T-spot TB test, there is that borderline region that I mentioned earlier, which is neither a negative or a positive result. It's important to put these tests into context and understand that, like the tuberculin skin test, the blood assays are useful but imperfect diagnostic tool. And at the end of the day, these tests cannot replace clinical judgment in terms of what to do with a patient. When we compare the two available tests, this table will highlight certain advantages of the blood test. So obviously the blood test is an in vitro lab test. Hopefully if the lab has appropriate quality control, then the results are reliable. The TST, being an in vivo test, is subject to many errors and subjective interpretation, as I mentioned earlier. The other advantage of the blood test obviously would be the fact that the person doesn't have to come back, and that in many instances is an important can be an important reason to choose one test or the other. If the skin test was a perfect test, but the person's not going to come back, it's a useless test. So the third important difference between the two tests is the kind of antigen used. And in the blood test, we use a TB-specific antigen as opposed to the PPD, which is essentially exposes the patient to an antigen that is present in many non-tuberculous mycobacteria, M. avium, M. kansasii, and M. bovis. That has a bearing on those who have BCG vaccination. So recommendations: either test are useful aids in diagnosing TB infection. You shouldn't be testing low-risk individuals, and the choice of test should be based on the reasons and context for testing, the availability of the test, and the overall cost-effectiveness of testing. CDC recommends that the IGRA can be used in place of the tuberculin skin test, and the following table will show you what the preferences are in specific situations. So the blood test is preferred for adults and children about 5 if the person you're testing is unlikely to return for a TST reading. One example would be sort of a migrant worker, a farm worker, those who are working every day and are not going to be able to come back and take off from work 2 days later. Those are sort of practical reasons to use a blood test. And the other important group to consider using blood tests for are people who have a history of BCG vaccination. For children younger than 5 years old, the tuberculin skin test is the preferred test. However, the Red Book as of 2012 says the IGRA is an acceptable test to use in children younger than 5. Contacts and the people that get screened regularly, either test can be used in this process. So summarizing testing strategies, routine testing with both TST and an IGRA is not recommended, especially for low-risk individuals. The results from both tests may be useful in specific circumstances. Repeating an IGRA or performing a TST may be useful when the initial IGRA result is indeterminate, borderline, or invalid. And lastly, the diagnosis of MTB infection and the decisions about medical and public health management should include epidemiological information, historical information, and other clinical information when using and interpreting the IGRA or TST test results. Again, it's important to take all of these other factors into context and not base your decision solely on a TST or a blood test result. So remember that if you've decided to test the person for TB infection, you have committed yourself to treating this person once identified to have TB infection, because you test them because they have a high risk. Now, once you identify a person to have LTBI or latent TB infection, it's important to do a thorough medical evaluation to rule out TB disease. So I mentioned earlier briefly about the symptoms for TB disease, which you might encounter every now and then with your clients. So it's a client that has a productive cough for 2 weeks and has been losing weight for the past month or so, and is known to have a positive skin test or a blood test. It's probably on top of your list to rule out tuberculosis. However, again, as I emphasized earlier, Persons who have latent TB infection should have no symptoms. Chest X-ray should be negative, and in some instances, baseline blood tests may be indicated. If the person has a positive skin test or blood test and is coughing, it would be prudent to probably rule out tuberculosis by doing 3 sputum smears and cultures for MTB. Now, once a latent TB infection is confirmed, these are the treatment options available. So here on the left is the recommendation and evidence rating for various regimens. And as you can see, 270 doses of INH or INH taken for 9 months is sort of the standard treatment for latent TB infection. However, about in November of 2012, a new 12-dose regimen was announced to be as effective as INH given for 9 months, and this is the 12 weekly doses of isoniazid and rifapentine, which should be given by DOT. Rifapentine is a long-acting rifamycin. So guidelines haven't come out with regards to recommendations and evidence rating for this regimen, but I would assume it would be probably A2 also when A1 actually when guidelines actually come out because it's been shown to be as effective. And then down the list you have twice weekly INH and 4 months of rifampin as acceptable alternatives given a B rating. Some situations that you might want to be familiar with, contacts, people living with HIV and pregnant women are some situations you might be confronted with. So contacts are important to evaluate immediately for infection and disease. For the most part, health departments do this, but there may be instances where the person may come to you as a contact, and for contacts, as I mentioned earlier, the risk for progression is high and should be evaluated immediately. If the initial test of a contact is negative, a repeat test about 8 to 10 weeks after is performed. The thinking is if the first test is done too early, the cell-mediated immunity may still be in the process of kind of maturing, and giving it a couple more weeks for a retest is the basis for this approach. Again, people living with HIV are high risk, and I'll discuss this in a little more detail in the next couple of slides. But INH given for 9 months is the regimen used. 12-dose regimen can be used if you have a healthy HIV patient who is otherwise not on antiretroviral therapy. Another important group to screen, maybe in your population, would be those who are getting prenatal care. It's a captured audience, so it's good to test, particularly the foreign-born individuals for high endemic countries, to get screened for LTBI. Once that's done, though, it's important, especially during pregnancy, to rule out TB disease radiographically. So it's not contraindicated to do an X-ray. It's probably prudent to wait the second or third trimester and obviously use a lead shield. And treatment for LTBI in this group can wait after delivery. About 2 to 3 months after delivery is suggested to be the time when treatment should be started. The other group are children. The preferred regimen, as I mentioned earlier, is INH given for 270 doses or for 9 months. In general, liver enzyme monitoring is not necessary for children unless they have symptoms or they're at risk for liver toxicity. For adult patients, in general, they should be evaluated monthly. They shouldn't be given a a prescription for the whole 9-month duration and not be seen in between. By doing so, at least by screening for hepatotoxicity, we avoid adverse events. Baseline liver function testing is not indicated routinely, but you may want to do this in particular groups, particularly those who have HIV infection, have alcohol abuse histories, are pregnant or have recently delivered, obviously those who have pre-existing liver disease or are at risk for hepatic disease or are on other hepatotoxic medication. The approach here is to withhold medications if their transaminases go up 3 times the upper limit of baseline and are symptomatic. That's nausea, vomiting, malaise, loss of appetite. Or if they're asymptomatic, the rise should be about 5 times the upper limit of normal. This is considered drug-induced liver injury, and the regimen should be stopped, and an alternate regimen should be considered. Adverse events are always to be reported, obviously. And these are the last several slides, a particular focus on LTBI and HIV because of the importance. For HIV-infected individuals, they should be tested for LTBI regardless of their risk as soon as their HIV status becomes known. A negative tuberculin skin test or blood test does not exclude latent TB infection, as they may have a compromised ability to react to these tests for TB infection. So the risk for infection is an important component of weighing whether or not the person might have TB or latent TB infection. Annual testing should be considered for HIV-infected individuals whose baseline is negative and have an ongoing risk for exposure to MTB infection by virtue of their socioeconomic history or their lifestyle. Another issue is after the initiation of antiretroviral therapy in those with particularly low CD4 counts, it's recommended that latent TB infection be repeated once the CD4 count goes above 200. As far as their treatment, once identified to have LTBI, the HIV-positive patient in close contact TB should receive treatment regardless of age, TB testing results, or history of previous treatment for LTBI. So if there's a strong epidemiologic link to an infectious case, the HIV patient is considered infected regardless of prior treatment and a negative test result. I'd like to underline that it's important to rule out TB disease and be HIV infected once found to have a positive TST or IGRA. It can be a little more challenging to diagnose TB disease in HIV-infected individuals because TB presents atypically among people living with HIV. Treatment of TB disease also has its challenges among those individuals living with HIV. If the person is receiving antiretroviral treatment, they should be treated with INH for 9 months. Rifampin would be contraindicated as an alternative drug if the HIV-infected person is on protease inhibitors or non-nucleoside reverse transcriptase inhibitors. In those cases, rifabutin may be substituted for rifampin. I mentioned this earlier, and HIV-infected individuals may be considered for the 12-dose regimen if they are otherwise healthy and are not on antiretroviral therapy. And the last bullet looks at test results for TB infection being negative. Treatment should be considered in the HIV-infected person if they might have had recent exposure to infectious TB, as we discussed earlier. Here are the resources that I have listed that you may want to take advantage of. Many videos that can reinforce what you've heard this afternoon from our website, globaltb.njms.rutgers.edu. There's a bunch of guidelines that are available through the website, training guides for skin testing, and treatment guidelines. Certainly, you can also use CDC resources, cdc.gov, where you have a lot of resources available for you. I'll turn it back over to you, Jennifer, for a few questions.
All right, thank you so much, Dr. Larzabal, for that excellent presentation. We now have some time for questions. If you do have a question, you can always type in the Q&A box, or if you would like to ask a question over the phone, you can press #6 to unmute yourself. So do we have any questions from the audience?
I have a question.
And can you say your name and where you're from, please?
I'm sorry, Donna Treese. I'm from Florida Department of Health in Escambia County.
Hello.
And I have had TB tests, the PPD, where they did the test, they read it, and then they did another test.
And what is the reason they did that?
They just said that that's what they do, is they have to do it twice. And I was doing travel nursing in Alaska when they did it, and I thought it was odd. I've never had that before.
No. Well, there is such a thing as a two-step test, and two-step testing using tuberculin skin test is really recommended only for those individuals that will be tested serially, like healthcare workers. Say a nurse is starting her job in a hospital X and has no baseline TST results. They do a TST at week 1. It's negative. It's advisable to repeat the test within the next 3 weeks to do the second step, because the tuberculin skin test sometimes may not remember. I mean, the T cells of a person may kind of forget these antigens, particularly if the infection's been remote, and so they might need to boost this reaction by doing the second test. For most,
I'm a nurse, and that was in a nursing home, so that.
Yeah, some people like to do sort of this boosted test in the elderly, but it's not really in any recommendations. But some people, particularly the elderly, may have sort of a weakened initial response to a TST. So sometimes some procedures or protocols in some nursing homes do that for the elderly.
Thank you.
You're welcome.
We did get one question from our Q&A box, and it is, what are treatment choices for breastfeeding mothers? And this is the last question we'll take.
Okay. Breastfeeding mothers, I've come across many mothers who have concerns about that. Certainly, if the baby or the infant is not on anti-TB treatment, or whether it's preventive or otherwise, the amount that comes through the breast milk is of very low quantities and dose, that it has no bearing or effect on the infant. So any of the choices are okay for a breastfeeding mother. For the most part, IMH or rifampin is used for this group. Again, caution if the baby would be on some form of TB treatment. There's no in a breastfeeding mother, there's no particularly preferred drug, and it's not contraindicated to breastfeed if you're on preventive therapy.
All right, thank you. And it is 1:01, so I think we're done for the day. I just have a few more slides to go through. This slide shows the continuing education information, and I will send all of you who joined us today an email with this information as well as the handouts for the presentation. In order to get your certification, you need to complete the online evaluation by December 19th. And this is the information for anyone watching the webinar archive, which will be posted shortly. And if you do have any additional questions, you can contact me at this email. And I'd like to thank Dr. Laterzabal for sharing his knowledge with us, and to all of you for being a wonderful audience. If you do have any additional questions, please contact me. And thank you, and have a great day.